Hi, dear friends. Good afternoon, dear friends. Good afternoon, Europe. Good afternoon, Africa, Asia, and the whole world. We have a lot of participants from all around the world, and it's really a very good time to discuss an important topic tonight for our patients, which is actually personalized cancer care. What do we mean from diagnosis to treatment? A very big problem in all the countries is that we have the same patients, we have the same diagnosis, but we have different treatments in different hands. So tonight, our dear friends, we have a lot of good, very well-known speakers, and we are all welcome. And on behalf of Engage, on behalf of patients, I want to once again thank to them that they spare their time and tonight they try to give us some lectures to make it more clear for our patients. My friends, our first speaker is Alejandra Martinez. Unfortunately, due to some other commitments, Alejandra could not make it. But thanks to her, as a council member and a very busy scienceman, she already prepared a video lecture for us. The topic is why are the tumors not all the same? So the tumor is different in one person, different in another. So what is the difference? Why are they are different? Yes, let's watch her.
Good afternoon to all of you, and sorry not to be here with you today. I'm going to talk about precision medicine. So, why are tumors not all the same? As an example, we have two women that walk into the same oncology clinic with the same diagnosis. One responds to treatment, but the other doesn't. Why? Well, the answer lies in tumor biology. And during this presentation, we will try to understand why the same diagnosis does not always mean the same tumor. Learn the 5 things doctors look for inside a tumor, which are genes, proteins, immune markers, the behavior of the tumor, and also the potential inherited risk when there are gene anomalies. And we'll see how precision medicine is changing treatment in different GYN malignancies so that you know which are the questions you should ask to your doctors. And we, after the session, will be better equipped to understand tumor biology and what to expect. So precision medicine is like matching the best treatment to the specific biology of each tumor, not only the organ it came from. So it's like ordering clothes online by saying clothes for a woman versus having the clothes tailored to your exact measurement. The right treatment for the right patient at the right time based on the biology of the tumor. So doctors look at these 5 things inside the tumors, and we will cover all 5 of them as we go through each cancer type. I'll give you some examples. So let's start with genes, which are like the body or the tumor instruction manual, and the proteins are the workers that are actually doing the job. For example, genes contain instructions that can help to repair the damaged DNA, and the protein produced by the gene actually performs the repair work. Then we have the immune system. So immune cells are like the security guards that protect the body and that should remove the tumor, should kill the tumor cells. And we have some immune markers to know if the immune system is working okay or not. These immune markers are like flags on the cells that can help doctors understand where the immune system is recognizing the tumor cells and fighting the cancer. Of course, we also have tumor behavior, which looks for the level of aggressivity of the tumor. For example, is it growing quickly or slowly? And finally, we have the inherited risk, which means that there are genetic anomalies that can be passed down to the family. So all three gynecological cancers have different targets that can be targeted with a specific treatment, always following the same principle. So testing the tumor and matching the treatment. For example, for ovarian cancer, we have anomalies in the BRCA genes that can enable us to give a treatment with PARP inhibitors, which is very efficient. And we'll now start with ovarian cancer, which is often diagnosed late because early symptoms are vague, and the majority of patients, like 70-75% of patients, are diagnosed at advanced stage. So the molecular revolution in ovarian cancer has been very important with PARP inhibitors that really have changed the survival outcome of patients. So in this section, we will cover what are BRCA genes, the testing, HRD, and this specific treatment that we call PARP inhibitors. And we'll also talk a few minutes of another protein that can lead to a specific treatment in patients who have relapsed and resistant disease. So BRCA genes are involved in the DNA repair system. When the system of repair does not work, then the system will fail. And PARP inhibitors, which are the specific treatment for alterations in the BRCA genes, can block the backup repair system. And without any repair system mechanism, the cancer cell cannot survive and then will die. So BRCA alterations in these genes are present in approximately 20% of patients with ovarian cancer, and testing for BRCA genes is now recommended for all patients with ovarian cancer, not only those who have a family history. And as these BRCA alterations will lead to a specific treatment, which is PARP inhibitors, and can also lead to discover the possibility of passing down this of an inherited risk and passing down these genes to the family. So here is one of the most important studies, the SOLO-1 trial, which showed the benefit of giving PARP inhibitors to patients with ovarian cancer. As many years ago, patients were only treated with chemotherapy and surgery, of course, and median progression-free survival was around 1 year. And thanks to the PARP inhibitors, this median survival was dramatically improved. So if you have a BRCA mutated ovarian cancer, the maintenance treatment with PARP inhibitors should be administered. And as you can see here, thanks to this treatment, now 67% of patients receiving this treatment for BRCA anomalies have overall survival at 7-year overall survival. Then we have HRD, which is homologous recombination deficiency, extending the benefit of PARP inhibitors beyond the BRCA mutated patients. So BRCA anomalies are the most common reason for HRD, so for a deficiency in the homologous recombination system, which is implicated in DNA repair. And about half of high-grade serous ovarian cancers, which are the most common ones, have a deficiency in this system and could potentially benefit of PARP inhibitors. But this testing for homologous recombination deficiency is complex, and it is not universally available, and access can actually vary among European countries. And as I showed you before, the Solo One trial, we also have the Paola study, which established the PARP inhibitors as maintenance treatment, so as a treatment that we give after chemotherapy, as a standard of care of patients with ovarian cancer and with a deficiency in this homologous recombination system. And this has even also implications for surgery, because, for example, early stage ovarian cancer does not have maintenance treatment recommended. But when we perform staging in these patients and discover that the disease is more important, which change the stage, we upstage the disease, and potentially these patients can also benefit from PARP inhibitors. So this information is also important for surgery. Then we have the last example for ovarian cancer, which is a protein, the folate receptor alpha, which is a protein that is expressed not in all ovarian cancers, but that can be targeted with a specific drug that we call mirvetuximab. And the mirvetuximab represents a completely new class of drugs for ovarian cancer, which we call an antibody drug conjugate. Which what does it mean? It means these ADCs, we call them, are like guided missiles. So the antibody is the guidance system that locks onto the folate receptor alpha, and the drug payload is the warhead that will kill the cancer cell. And because folate receptor is barely present on normal cells, the toxic payload is delivered almost exclusively to cancer cells, reducing the off-target side effects. And for platinum-resistant ovarian cancer, which is a clinical setting in which options are very limited, this has been an important advancement to improve patients' survival. So now let's move on to endometrial cancer, so the uterine cancer, which is the most common gynecological malignancy in Europe, and its incidence is rising with the increasing obesity rates. And for many years, the treatment was guided purely by histology and by stage. But now the molecular classification has been really a paradigm shift and has identified 4 different entities, 4 different subtypes that have very different prognosis and also different treatment implications. So like 10 years ago, for example, a grade 2 endometrial cancer, which is the most frequent one, was always treated the same way, regardless of what was happening at the molecular or at the protein level. So 2 women who had the same disease and the same stage could have completely different outcomes. One could be cured only with surgery, and another would die of metastatic disease within 2 years. And why? Because there were different molecular anomalies among the tumor, different protein expression among the tumor. Now, thanks to molecular classification that can be done in most of the pathology labs, we can adapt the best treatments. So which are these molecular groups? So now we can class endometrial cancers in 4 different subtypes, which are, you can see here, the pole, a bit less than 10% of endometrial cancers. which have a very, very good prognostic outcome. And in these patients, we can de-escalate treatment after surgery. The majority of cases can be cured with surgery alone. Then we have the MMR deficient tumors, around 1/3 of patients that can be treated, that these tumors are very sensitive to immunotherapy. That has now become the standard of care for patients who have advanced disease, and can potentially be associated with a genetic syndrome, so with inherited risk in a minority of patients. We then have in orange, yellow, the NSMP, so no specific molecular profile, which is the most frequent group that can now be divided according to hormone receptors, as some can respond to hormone therapy. And finally, we have in red the P53 abnormal, which is the most challenging and group. These patients have poor prognostic and require intensive treatment. So let's talk 2 minutes about MMR, which are these proteins that are a marker of sensitivity to immunotherapy. And universal MMR testing is now recommended by ESGO for all endometrial cancers. And these MMR are proteins that are implicated in DNA replication. So we should do universal testing of these proteins. Why? First, because it will modify the treatment, and these patients can benefit, as I told you, from immunotherapy. And second, some patients can have inherited risk, which we call the Lynch syndrome, which is predisposing to endometrial and colon cancer. And the only reliable way to find Lynch syndrome is to test the tumor and to look for this hereditary syndrome, as family history can miss around 50% of Lynch syndrome carriers. So when confirmed, the family members can be tested if this inherited risk is demonstrated and be offered specific surveillance or even prevention surgery. So for MMR tumors, I said that immunotherapy, these tumors are very sensitive to immunotherapy, and this has been demonstrated in several trials. We have these two studies, which are landmark trials that were published in the same issue of the New England Journal of Medicine, which is a very important medicine journal, showing the benefit of immunotherapy in these patients that is associated with a reduced risk of progression by approximately 70%. So very important benefit. And finally, we have HER2 testing, which is also done, for example, in breast cancer, which is recommended in uterine serous carcinomas, which are the most aggressive, or one of the most aggressive subtypes of endometrial cancer. So the HER2 protein, it's a protein that will act like a gas pedal stuck in the on position, driving cancer cells growth. And we have a specific drug, which is trastuzumab, which is the same drug that we use for breast cancer, that will block this signal and slow the tumor growth. And this drug can only be accessible if the HER2 testing is done, and if the treatment is available also in your country. So all advanced and high-grade endometrial cancers should now have this molecular classification to know if the tumor belongs to one of these 4 subtypes that have different prognostic outcome and, of course, different treatment implications. And now the ESGO guidelines recommend that all endometrial cancers undergo the molecular profiling. And so this has been this is now the standard of care in many European countries. So finally, we'll talk a bit about cervical cancer. 95% of cervical cancers, as you know, are caused by HPV. So this is a preventable disease, as we can do vaccination. Very important. This is the key message. And we also have a screening that is a very important prevention tool for cervical cancer. But however, in relapsed, recurrent or metastatic disease, the options for these patients have historically been very limited, and the addition of immunotherapy to first line to chemotherapy, guided by a specific test that because we call the PD-L1, I'll talk a bit about it later, has improved outcomes in this difficult setting. So what is PD-L1? Well, we have to think of the immune system, as I said, as the army. These are the bodyguards that should kill the tumor. And PD-L1 is like a white flag that cancer cells can show and wave it to stop the soldiers attacking. And immunotherapy, for example, the pembrolizumab, which is one type of immunotherapy, can remove this white flag so that the immune army sees the cancer again and be able to attack and kill the cancer cells. So the majority of cervical cancers express PD-L1 so that the immune system gets blocked and does not attack these cells. And immunotherapy will remain this stop signal, this white flag, so that the bodyguards attack and kill the cancer cells. And we have this study that has established the immunotherapy as the standard of care for patients with recurrent and metastatic disease, as PD-L1 is expressed in the majority of patients. So adding immunotherapy can improve patient survival and adding additional months of life. And as you can see here, the cervical cancer treatment landscape is evolving. We have another study that has extended the immunotherapy to locally advanced disease. So these patients have been treated, that are treated with chemoradiation, which is a far more common clinical setting than the metastatic setting. And there are also ADCs, we talked about them previously, that are now being tested for cervical cancer. So just to end, finally, inherited cancer risk can be associated to some gene anomalies, and these genetic syndromes can affect the whole family, not only the patients. So when a patient discovers that they are carrying these abnormal genes, such as the BRCA or the Lynch genes, they can take life-saving preventive actions before the cancer develops. For example, BRCA1 carriers have 40% of lifetime risk of developing ovarian cancer compared to 1.5% for the general population. So early identification of this genetic anomaly can lead to prevention surgery to reduce this risk nearly to the baseline risk. And there are many multiple decision points where molecular testing can be performed, but it should ideally happen before the treatment starts. As you can see here, so step 3, we have the diagnosis with the biopsy, the analysis at the pathology lab, and the molecular testing to adapt the treatment. And what are future directions? Just to let you know that there are many ongoing markers and studies, and these treatments that are now in clinical studies and clinical trials will be the standard of care probably in 5 to 10 years. So I encourage you to participate to clinical studies, and thank you very much for listening. Goodbye.
Okay. Thank you so much, my dear Alejandra. You are not hearing us, but we heard your lecture very, very fantastically. Dear friends, our second speaker is just coming up. Is Ian McNish, is a very, very popular name, and we have the chance to listen him many times in ESGO. He has a lot. He did a lot of job in the literature, and today's topic is how we can make from the test result to the treatment decisions. Ian, are you with us?
I am with you.
Yeah, we are waiting for you.
Right. I apologize if there's a lot of background. I'm in a public space after a work meeting. Anyway, good evening, everybody. It's a pleasure to join you this evening. I make no apology that a lot of what I am going to explain to you in the next few minutes is similar to what you've just heard from Alexandra, but I think it's important to emphasize and repeat the information. So I've been given the title of Test Results to Treatment Decisions in Gynecological Cancer. I always have a declaration of interest at the start of my talks. So what I will discuss in the next few minutes are basically three things. A quick reminder of biology for those of you who left school a few years ago, the different types of tests that we do, and then again, repeating some of what Alexandra said, what do we test in gynecological cancers? And more importantly, why do we make those tests? So just to remind you about DNA, RNA, and protein. So every cell in your body contains about 2 meters of DNA wrapped up into a very small ball. And the DNA of every cell of your body, more or less, is identical. So if we say that is the code that drives you, it is a perfect description of you. RNA is the specific instruction, but proteins are what do things in cell. Everything in your cells and every cell of your body is done by a protein. So hemoglobin is a protein. The hair coming out your head is a protein. Proteins do everything. The other thing to understand is what is a gene? I would describe a gene as one sentence of code within your DNA, and that sentence describes one protein. So, as I said, the DNA in every cell of your body is about 2 meters long. There are 23,000 different genes within that DNA, and each gene describes or encodes one protein. Abnormalities in DNA are called mutations, and there's lots of different ways in which DNA can get mutated. But for the purpose of this evening, there are 2 things to understand. There are mutations that we call the germline. So those are mutations that you inherit from your parents and can pass on to your children. Those are germline mutations. And then we have what's known as somatic mutations. Those are mutations that only happen within tumors. And obviously they cannot be passed on to your children and they cannot be inherited from your parents. Germline and somatic is a very important differential to make. So how do we test for mutations? Well, we use a technology called next generation sequencing, which involves taking the DNA from a tumor or from your blood, chopping it up into small pieces, sequencing it, and then the clever bit is here in the bottom right-hand corner, is where you align, where you take all of that DNA and you reconstruct it, and you compare it to normal DNA and say, okay, where are the abnormalities? Where are the mutations? That's the clever bit. That's the bit that requires computation and takes time. And there are multiple different types of next generation sequencing. But again, for the purposes of today, we do two types of testing. We either measure one or two specific genes, and we look at them in very, very, very great detail, or we do what's known as whole genome sequencing. We look at the entire DNA, all 2 meters of it in every cell, and you get different answers because it's asking different questions. And again, I will go through that in a minute. So as I said, everything in every cell of your body is performed by a protein. And the way that we test proteins is a test called immunohistochemistry. So if a surgeon does an operation or we take a biopsy, that then goes to the pathology department, where our colleagues in pathology do a test called immunohistochemistry, which basically is looking for one individual protein. And it works by taking the tissue, cutting it into very thin slices, and then adding antibodies that recognize the protein that you are interested in. Proteins can exist in multiple forms, but very briefly, pathologists look for 3 patterns. They look for proteins in the nucleus, the DNA of cells. They look for proteins on the outside of cells, which we call the membrane. And then they look for proteins in what we call the cytoplasm, which is the inside of the cell that is not a nucleus. And again, I'll show you some examples in a minute. So testing specifically in ovarian cancer. So as Alexandra said, we look for mutations specifically in 2 genes called BRCA1 and BRCA2. And how we do that is to test the DNA in the blood of the patient and also in the tumor of the patient. And we know between 10 and 15% of women with high-grade ovarian cancer will have a germline, an inherited mutation in one of these 2 genes that they've inherited from their parents. Around another 5% of women have somatic or tissue mutations just within the tumor. So these have happened spontaneously within the tumor itself. And that's why we need to measure both the blood and the tumor. So why do we test for these mutations? Again, Alexandra's shown you this slide, but the most important reason for testing is that women who either through a germline mutation or a mutation within the tumor, if they have an abnormality in BRCA1 and BRCA2, I'm just going to go and stand in a quieter room for 2 seconds. I do apologize. They are spectacularly sensitive to a drug called olaparib. And again, Alexandra showed you these slides from Solo 1. So all women with a BRCA mutation should receive treatment with a PARP inhibitor called olaparib. But of course, the other reason we test for mutations in BRCA1 and BRCA2 is because in 10 or 15% of our patients, it is inherited from your parents. And if a woman has a BRCA mutation, each of her children has a 50-50 chance of carrying the same mutation, which obviously has implications for their risk of breast and ovarian and other cancers. So again, in my center, if we find an inherited mutation, we automatically invite the daughters and the sisters of our patient to be tested. So the other thing we test for in ovarian cancer is this concept of HRD, which we test in the DNA of the tumors. And if I tell you that the DNA in high-grade ovarian cancer is basically completely chaotic, what I mean by that is on the left, we're looking at the DNA in a normal cell. And we're looking at the 22 chromosomes that you have. And when you're conceived, you inherit 1 set of chromosomes from your mother and 1 set of chromosomes from your father. And every cell in your body has 2 copies of everything. The pattern you see in the middle is the pattern of chromosomes in 1 high-grade ovarian cancer. And as you can see, it's completely chaotic and all over the place. And we've now found assays that can measure the degree of chaos within the genome in the DNA of high-grade ovarian cancer. And to summarize 10 years of my life, I can tell you that cancers that are particularly chaotic are what we call HRD. And there are now tests that we can do routinely in the hospital that are quantifying the amount of chaos in the DNA of a high-grade ovarian cancer. And that's what we call HRD. Why do we measure that? Because patients whose cancers show HRD, even if they don't have a mutation in BRCA1 or BRCA2, they also benefit from having a PARP inhibitor. So these are data, again, Alexandra mentioned them, a study called Paula-1. On the left, you see the patients whose cancers were classified as HRD, and they benefit from having olaparib treatment. And on the right, you have the patients whose cancers did not have HRD. And in those patients, treating them with olaparib does not help at all. So again, in my center, we test all tumors at the time of diagnosis. And a woman who has an HRD tumor without a BRCA mutation, we offer them treatment with olaparib and bevacizumab. Endometrial cancer has changed dramatically in the last 5 years. And we now test for 3 separate things in endometrial cancer that helps us guide treatment and also give us information about prognosis. So what do we test? So we test for 4 proteins by the names of MLH1, MSH2, MSH6, and PMS2. So we measure the protein in the cancer, and those 4 proteins are all involved in a process called mismatch repair, which basically means they're involved in making sure that when your DNA replicates itself, it does so perfectly accurately. And if you have an abnormality in any one of those proteins, your DNA does not replicate, does not copy itself accurately, and you get lots of mutations. The second thing we test for is a protein called P53. And when this is mutated, you get several patterns, abnormalities of protein that, again, you can measure in a tumor biopsy using the test we called immunohistochemistry. So why do we test these things? So the first one is POL-E, which we measure by looking at the DNA. And as Alexandra said, endometrial cancers that have mutations in POL-E do amazingly well, even without chemotherapy. And so you can see on this graph, women whose cancers had a POL-E mutation, 98% of them were alive and well and relapse-free 5 years after diagnosis. By contrast, tumors that have an abnormal P53 unfortunately do much less well, and 50% of those cancers have recurred by 3 years. The cancers that had deficient mismatch repair did better, but still about 20% of those recurred within 3 years. So this is what we call prognostic. So these testing for these 3 things gives us information about how well the patients will do. But beyond that, it also now, as you've heard before, helps us guide our treatment. And we now know that cancers that have abnormalities in the mismatch repair process respond brilliantly well to immunotherapy. So these are data from a trial called Ruby. All of these patients had very advanced or recurrent endometrial cancer. With standard chemotherapy, most of the patients had already progressed within 12 months. But as you can see, those patients given immunotherapy with a drug called dostarlimab, although some of them relapsed, by the time you got to 12 months, if the patients who had not progressed within 12 months, they seem to be able to go on forever. And these patients with recurrent or metastatic disease may even be cured long-term with immunotherapy. The third reason we do these tests is obviously to help us design our clinical trials. And there's a large European trial called Rainbow, which is testing 4 different treatment options in women with endometrial cancer, depending on the outcome of their testing. So the P53 abnormal patients we knew tend to do less well. We're trying them with chemotherapy, radiotherapy, and olaparib. The women with mismatch repair, we're trying a different immunotherapy called durvalumab in combination with radiotherapy. The women with POL-E mutations may not need any treatment at all, and so they're just having surgery without any chemotherapy or radiotherapy. And then the remaining patients, we're going to give them hormone treatment. Finally, I'm going to talk about cervix cancer, which, although becoming less common in Europe, is still the commonest gynecological cancer worldwide. And as you know, and as you've heard, it's caused by a viral infection with human papillomavirus that can now be prevented with vaccination. That vaccine needs to be given to girls before the age of 13. But the reason we obviously vaccinate is to prevent cervix cancer. For women who are older than that, we now use HPV testing as part of cervical cancer screening, because we know that women who are HPV negative, when they have their smear, their chance of getting cervix cancer in the next 5 years is incredibly low. And in those women, we can de-escalate their screening. Whereas in women who are HPV positive, then we need to be more aggressive and follow them up much more carefully. One of my medical students asked me recently, how good is the human papillomavirus vaccine? To which the answer is spectacularly good. So these 2 graphs come from paper from UK studies, both of which show that in girls who were completely vaccinated against HPV by the time that they were 13, if you then follow them up for 10 years, absolutely zero cases of cervix cancer are seen. So the protection offered by HPV vaccination is incredibly good if that vaccination is done before the age of 13. In women who do have cervix cancer, then the one thing that we test for is this protein called PD-L1 that you've heard about. So this is a protein that gives an indication of the state of the immune system within cancers. Again, it's a protein test done by immunohistochemistry. And we do what's known as we give it a score called the CPS, the complete positive pathological score. And what pathologists do is they take a tumor, they stain it for PD-L1 by immunohistochemistry, and count the percentage of cells, not just tumor cells, immune cells, every cell that is positive for PD-L1, so has this brown staining. And we divide it into 3 groups. Those where there are essentially no cells that are PD-L1 positive, so they have a score of less than 1%. Those who have a score between 1 and 10%, and those who have a score of more than 10%. And why does that matter? Because in cervix cancer, if you can see, here's a trial of women with advanced cervix cancer given chemotherapy and then either a placebo or immunotherapy with pembrolizumab. And if you take the whole trial population on average, there is a very good effect. But if you look on the right, you have what we call a forest plot. This is a way of looking at subgroups of patients within a clinical trial to see, do some patients benefit more than others? So at the top, we have the overall population. We look at older women and younger women, there's no difference. If we look at white women and non-white women, there's no difference. But when we look at PDL scoring, then the women who have a score of less than 1, effectively all cells are negative, there appears to be no benefit to adding the pembrolizumab. Whereas if you look at women with a score of 1 to 10, or women with a score of over 10, there is a significant benefit from pembrolizumab. And that's why, certainly in my country, also in the rest of Europe, pembrolizumab is licensed to be treated for women with cervix cancer, where the PDL1 score is at least 1. So, in summary, there are a whole bunch of molecular tests that we do for women with cervix cancer. They are important for telling us prognosis, how well patients will do, but also important for guiding the treatment that we give patients. And those tests are incredibly important and are now integrated into the care that we give patients every day. So I hope that made sense. I hope it was clear, there was not too much noise, and I thank you very much for joining us this evening.
Thank you so much, my dear Ryan. It was again one wonderful presentation, very shortly, very briefly summarizing where we are in the molecular diagnostics tests. So we are moving towards our third speaker. I think the third is Alia. Are you here, or Sarah?
I think it's me, Murat.
Okay. So Ali will discuss about, as a patient, it's a very complex. I'm sure. I mean, the slides were difficult, but what do you think as a patient? What you should ask to your doctors to understand more your disease? Let's see from the patient perspective of all these new technologies.
Great. Thank you very much. Thank you very much, Murat, for the introduction. I'm just going to put my camera off for the duration of the presentation. So my task was to really add on to what Alejandra and Ian have already really beautifully and in detail explained, with the aspect of how can we explain complex medical language in a more understandable way to you as our patients, and what can you ask us that is important in a consultation. And we'll hear more about that when Ellie speaks after me. So I will repeat some things that Alejandra and Ian have already mentioned. There's really a lot that has been happening in cancer care over the years, particularly moving from the aspect of one size fits all to precision medicine, which is what we're talking about. I'm giving a brief history for endometrial cancer in particular. So if you think about that, in the 50s and in the 80s, the standard therapy was radical surgery and radiation therapy for all patients with endometrial cancer. We're now really moving very quickly into a very different aspect of cancer care. So we started off in the 50s and in the 80s with surgery and radiation being the therapy options that were available. In the 80s and the 2000s, we moved on to chemotherapy. So carboplatin and paclitaxel became a standard of treatment for advanced endometrial cancer or cancers in general, regardless of the tumor biology. And then in 2013, really the main turning point happened with the Cancer Genome Atlas. Alejandra and Ian have both mentioned it already. And the Cancer Genome Atlas is really the largest and most important public cancer genomic library, really, evaluating over 20,000 cancer, looking beyond the tumor histology and the tumor type, and also looking at the molecular and the DNA composition of the tumor. And this is where we really got a lot of information from, and where then, starting from 2015 and 2020, we started looking at biomarkers and biomarker-guided treatment. Alejandra and Ian have already mentioned the mutations that began driving treatment decisions, particularly in endometrial cancer, the POLE mutations, MMR status, and P53 mutations. And then from 2022, so not really that long ago, until today, we're now even looking at much more accurate and more targeted therapy, looking at immunotherapy and immune checkpoint inhibitors. So this is where pembrolizumab and dostarlimab, the medications that Ian has already mentioned, are coming into play. So what is precision medicine? Precision medicine is really just means tailoring your treatment to you. So not just to the diagnosis, but to the very specific features of your cancers. So we have the traditional approach, looking at the same treatment for everyone with the same type of cancer. What we're moving into is looking at treatment guided by the unique biologic composition of your cancer. And the goal is to really find the treatment that is most likely to work in your case, and to avoid treatments that are less likely to help you. What we've also mentioned is molecular testing. This is what we're actually doing as part of the cancer journey. We're looking at the tumor cells. And what we're looking much more closely into the cancer and how the cancer actually behaves. So when a sample of your cancer is removed during surgery or a biopsy, what happens is scientists analyze it in the laboratory and they look at the cancer's genetic makeup, so looking at the molecules and the genes, as if they're reading its instruction manual. And Ian has explained this very well in his slides. We're doing that to understand what is actually driving the growth of this cancer. The important thing is there's no need to understand every technical details, but what matters is knowing why we're doing certain molecular testings, and most importantly, what the results actually mean for your particular care. I always explain this as two different aspects. There's the academic aspect, so all the research and the science and the information and the data that we gather. And then there is actually the information that is relevant for your particular case at this particular moment in time and what consequences it can have for you. So one of the things that Alejandra and Ian have already mentioned and that we've gone through is a mutation. So what is a mutation? A mutation is simply a change in the instructions that tell a cell how to behave. So it's like a typo. And this is how generally I explain it to my patients. DNA is like a recipe book, and a mutation is a typo in one of those recipes. And some typos don't have any effect overall, but other typos can cause problems, so wrong instructions leading to the cells growing out of control. And these mutations, so these typos, are very useful clues, because knowing which typo is present helps the doctor choose the right treatment. So basically like finding the right key for a specific lock. And this is why we do molecular testing. This is what is currently also possible in precision medicine. So some words that you may hear during your cancer journey, your treatment journey, is the word biomarker. And biomarker is a feature of the cancer that actually may give useful information to us as clinicians. So basically like a clue about how the cancer is likely to behave or respond to treatment. So this is where the mutations that we spoke about earlier, so the MMR, the mismatch repair, the POL-E mutations, these are all practically DNA spell checkers. And if there is a change or a typo in those spell checkers, this will lead to specific mutations and can mean different things for the treatment of the cancer. Molecular testing is the way we look for these specific mutations. So this is where we're examining the cancer's genes to guide treatment. An actionable result. So when I was mentioning about there is two aspects to the treatment. There is an academic aspect, so where we're collecting all the information and all the data, and then there's an actionable aspect. That is the actionable result. So it's the result that actually may influence the treatment and may actually change the plan. Not every typo in the instruction manual leads to an outcome that can necessarily change the plan, but some do, and they're important to know about because we can actually act on that and target the treatment so that you receive the treatment that's most likely to work for you. However, although precision medicine, as we've explained it, is very useful and has helped us really find the most suitable treatment to target it to specific tumors, it doesn't always give a clear-cut answer. And this is sometimes where a lot of frustration can arise. So results can mean different things for different people. The way I tend to explain it sometimes, it's like a weather forecast. So, for example, 70% chance of rain is useful information. You can prepare, but it's not a guarantee. So in the same way, a test result, like in many other things, can increase or decrease the likelihood of a treatment working, but again, without giving a definitive answer or a guarantee. So for you to understand, it's completely normal to have results that may need further discussion. And that uncertainty is sometimes also part of the treatment journey. It is not necessarily a sign that something has gone wrong. So feel free to ask any questions. Your voice matters, and asking questions is important, and it's an important part of getting the care that you actually deserve. So the questions to ask is, why is this test being done? So know exactly what could the outcomes be of this test and what would happen with each outcome that is possible. Also, what might the results actually mean for you? Make sure that if you don't understand the terminology, ask for plain language. And then, and this is where sometimes a lot of confusion happens, is asking what happens next. Maybe for us as clinicians, it's very logical that these would be the next steps. But for you in your journey, this is a very unique experience to you. So ask, what would be the next steps? What is the next logical steps? And how does the action plan actually look like? I did include a slide on AI, simply because over the last years I've had many patients come in having asked ChatGPT or any other AI tool about test results, about treatment results, about the evidence that is there. And this is open also for discussion. It would be interesting to hear your thoughts and your opinions on this. AI tools can be helpful, but we need to use them with caution. So they can help sometimes summarize certain reports. They have been used to translate reports, maybe into medical reports, into plain language. And they have been used also to prepare questions about a specific topic before you actually come and see us. This can be useful. However, AI tools are not 100% accurate, and they do make mistakes, and they may not actually answer your questions correctly. They may not pull out the correct information. So please always check and discuss any findings, anything with your caring physician or with your care team. Alejandra has already explained how the testing that we do fits into your care. So the sample is collected, either tissue biopsy or during surgery. There is molecular testing is performed actually very early on in your journey, in your treatment journey, so that results can be reviewed and you then have a personalized treatment plan tailored to those results. So in order to summarize this, what can molecular testing or precision medicine in general do, and what can it not do? It can most definitely help identify which treatment are most likely to work for your cancer, for your particular cancer biology. It helps us guide decisions about whether additional therapies may help. It can also provide information about the likely course of the disease. And again, here there's no guarantee. And it can open doors to existing clinical trials that match the cancer's profile. What it cannot do is guarantee a particular outcome, and obviously always provide a clear or simple answer. Sometimes there are uncertain answers. It most definitely does not replace a conversation with your caring physician and any of your questions. And also it does not work the same for every patient. Okay. So this is a summary of the main mutations with regards to endometrial cancer. They have been mentioned before. This is a summary of it as well. This is what the evidence is currently. The Cancer Genome Atlas in 2013 has identified the 4 molecular subtypes of endometrial cancers. They have different outcomes. To summarize briefly, the Pol E mutation, this is a type of, Pol E is a DNA spell checker, and a mutation in the Pol E can cause the tumor. However, they tend to have a better course of disease. So we may, in these cases, avoid additional treatment or aggressive treatment. The MMR, which is the mismatch repair, apparatus is again similar. It's a spell checker or repair mechanism for the DNA of the cell. If there is a deficiency in that, so a change or a typo, then that can cause the tumor. However, those tumors that have this deficiency, they respond well to immunotherapy, particularly pembrolizumab. The P53 mutations, they tend to be more aggressive. So you would have more intensive treatment courses for patients with P53 abnormalities. So in summary, and as a key message, your cancer and its biology is unique, so your treatment should be as well. Always ask why. So what is the purpose of the test? Ask what it means. And please make sure that if there is any terminology that we're using that you don't understand, clarify. And ask what are the next logical steps. Thank you very much, and I look forward to your questions. And I will leave the word to Ali. Thank you.
Okay, from the patient side, Ali, we are with you. Can you? We cannot hear you, Ali. We cannot hear you.
Can you hear me now?
Okay. Please share your slides.
I don't have. Just give me...
Okay.
No. Just it will be just me speaking. So thank you very much for today for asking me to be part of this webinar. My name is Ellie, and I'm an endometrial cancer survivor and a patient advocate. When I was diagnosed with endometrial cancer in 2020, I felt completely lost, and I had no idea what that was, what it meant for me, or how it would change me. Facing a cancer diagnosis is completely overwhelming. Like most patients, I did not know what to ask and when to ask. I remember my first appointment with my oncologist. I just sat in his office and nodded because I just didn't know what else to do. It is impossible to think after you've heard the news. So it's very important to have someone with you, especially during your appointments, a partner or a friend or a family member, because 2 people are definitely better than 1, especially when your mind is likely screaming cancer and nothing else can be absorbed. So there's no right or wrong time to ask. For me, the answer is that you should always ask, whether it's before your treatment, during the treatment or after, or even way later when you may have some concerns about recurrence, or you feel stressed, or something just doesn't feel right. You should always be encouraged to talk to your doctor and ask them to explain. Most of us don't know that two patients with exactly the same diagnosis could end up receiving completely different treatments. We don't know that a tumor might have specific features that could change what treatment is right for me specifically, and not just for someone else with the same diagnosis. Like same diagnosis, different tumor, different treatment. And that is precision medicine in real life, and it's happening now for patients like myself and many others I know. So questions that patients should always ask are, has molecular testing been done on the tumor? Would the result change the treatment options? Am I eligible for therapy or immunotherapy based on my results? Do I need genetic counseling if someone has family, and how that would affect them? Is there a clinical trial that I could qualify for? Or very simply, can I just have a copy of my test results? These are simple questions, not simple, but these are questions that every patient should be able to ask. And they are relevant at every stage of the journey. I personally was very lucky to have my doctor with me every step of the way, because with any fears, side effects that make you panic in the middle of the night, non-stop tears, you can ask and they can explain it to you. So personally think that during a patient's treatment, the connection, trust in the doctor, the connection, the trust with the doctor is very crucial, because you trust them with your life and you hope and believe that they will do the best they possibly can. The diagnosis is a starting point, but not the full picture. So for me, my cancer had a name, like endometrial cancer, but that name alone doesn't tell my doctors everything they need to know. And thankfully, modern medicine now can look closely at the tumor itself and determine which treatment is more suitable than another. As a patient advocate and as someone who has been through this personally, I know that not all questions can be answered during a single appointment. Time is short and there's a lot of information to absorb. So just go back and ask. You have the right to ask, and the doctors will explain. Like patient organizations like ENAGAGE exist precisely for this reason. It's to help find the right questions, understand the answers, and feel less alone in the whole process. And as it was mentioned earlier, we don't need to understand every scientific detail, but we have the right, though, to understand why a test is being done and what the result means for our care. As patients, we have the right to ask whether precision medicine options are relevant in our case or not. Thank you.
Ali,
Yes.
thank you so much. I think we have no questions tonight. Sarah, do you want to make any comment, dear friends? Nothing. So I think we learned a lot tonight. I personally learned a lot. These slides are better for me as a surgeon. Learning the molecular diagnostics is also difficult. So after a lot of surgery, somebody is finding any molecule, and we are reading hundreds of articles. Thanks, Engage. As a doctor, I want to thank, because it's really I am learning in Engage presentations too. Okay, so we would like to thank our sponsors always, AbbVie, AstraZeneca, and Genmab. Really, without their support, these types of international meetings, especially for our patients, who deserves the best in the world, the real fighters, we cannot do it. Thank you all. Thank you, and a good evening to all of you.